Good morning, everyone. My name is Shooq Alshehhi. It's a privilege to present today alongside my colleague, Ganna Mohamed, your intern SKMC. Under the supervision of Dr. Antoine, we're going to present a case of atypical Kawasaki disease, presenting with myocardial infarction and the thrombus formation. Next slide. Next slide, please. Thank you. So this is a case of a 13-year-old male who's an avid football player. He presented a year ago with atypical Kawasaki disease. He came to the AD with the features that is unusual, like Roth spot, which is defined as a white-centered retinal hemorrhage, which is usually seen as an immune sequelae, like a patient presenting with endocarditis. So they did for him an echo that confirmed a mild bilateral coronary artery dilation that is prominent. And the patient has been then discharged from the ward after a prolonged course of inpatient requiring IVIG, ICU support, steroids, and biological immune modulators like infliximab for Kawasaki with progressive bilateral coronary dilation. And he was discharged with the dual antiplatelet, clopidogrel, and aspirin. Can you go to the next slide, please? So he came to the clinic in June 2024 with a complaint of chest pain that started 3 hours ago while he was playing football. It was left-sided chest pain radiating to his left shoulders, characterized by heaviness and associated with diaphoresis. It was then showed that the patient was not compliant with his dual antiplatelet, telling his parent as he was feeling ashamed of the bruises that used to appear when he plays football. And an interesting fact to mention here, that even heart disease, that everything have a season, even heart diseases. So we know that plug ruptures usually, which is very common cause for adult angina, ties during the winter, and that's because cold temperatures, they can lead to vasoconstrictions as well as high blood pressure that can trigger the plug ruptures. Other interesting fact is that during winter, we have the influenza season, so which usually can cause inflammation, and this can be the cause for the tip that. So therefore, this can also increase the acute coronary syndrome during winter. However, the plug erosions, it's usually higher in the summer, as in hot weather, people, they're more likely to be dehydrated. So it's important to put this in our mind as in such a case for this patient who came in the summer, hot summer in June, while his symptoms occurred after he played football. So moving to the next slide, please. The patient has been admitted and the investigation showed that he had a high level of cardiac enzymes. The troponin reached up to 148, and ECG shows a Q wave and the lead V1 and V2, which is highly indicative of presence of MI. Echo then shows that there is a segmental dyskinesia and a large clot in the left anterior descending artery. And during the second day of the patient admission, the patient had a cardiac collapse due to sudden complete heart block as a complication of MI. So code pink has been activated and they sent him to CAFA for temporary pacing. Moving to the next slide, please. So discussion were there between adult and pediatric cardiology department regarding the angiography. And as we know that usually pediatric cardiologists, they may not have an extensive experience as adult cardiology in the thrombolysis and MI cases, while adult cardiology, they typically don't treat children. So discussion was there, and after that, it ended up that adult cardiology, they accepted to do the angiography for this patient.
Next slide, please. So while we were waiting for the angiography to be done, a speckle tracking echocardiography was done. So STE is basically a novel technology that tracks the motion of each myocardial segment and measures the strain, which is indicated by the numbers that we can see here. Negative numbers would indicate shortening, while positive numbers would indicate lengthening. So on the diagram on the right, the pale area shows a decrease in the contractility compared to the rest of the myocardium, as you can also see from the numbers. So where do you think that region is? A quick recap, we can use the bullseye diagram that is there in the end of the picture on the slide, where distribution of the coronary artery showed that the pale region corresponds to the LAD territory. And let's keep this in mind because, can you please go to the next slide? Yeah, so when the coronary angiography was done, it showed a thrombus in the LAD, as we can see on the picture on the left. and on the right coronary artery dilatation, as we can see on the picture on the right. Next slide, please. After that, fibrinolytics were started for our patients, and the thrombus almost resolved. And on discharge, his ECG showed sinus rhythm, and he was discharged on warfarin and antiplatelets. Next slide, please. So the take-home message from this case, that this case highlights the importance of interdisciplinary approach and coordination for pediatric patients that present with adult presentation to overcome any challenges and manage the cases effectively. Roth spots can be a possible negative prognostic factor for Kawasaki, and should fundus examination be a part of Kawasaki assessment? And also importance of STE in predicting with high sensitivity the findings that would show an angiogram, and compliance to medication and how it can affect the outcome, and types of anticoagulants based on the size of aneurysm. For example, for large aneurysms, dual antiplatelet was given, and for giant, antiplatelet plus anticoagulation was given.
Wanted to thank Dr. Najib because he was of great assistance during the diagnosis of the case. I was sending him updates of the case, me and the team, and he helped a lot in managing the case. So I wanted to thank him as well because he's one of the people that participated in getting this kid to sinus rhythm again, and in discharging him in the best shape possible. So we are happy to hear any questions, any comments.
Yeah, thank you, Antoine. Thank you for your trust. But I also would like to thank everyone to be listening to each other, because no one has the absolute knowledge of Kawasaki disease. It took us so many years to know as much as we know now individually. But with communication, we were able to save many, many situations and many lives all across. So communication is very important. And I don't think that I know everything, which is great, because only when you know that you don't know, then you will get to know more. So this is a great situation where, yeah, collaboration and understanding and accepting the other one's opinion really help. And there are many cases all across the world. I would like also to invite everyone to consider these cases of intervention, acute coronary artery problems in Kawasaki disease, to be part of a multinational registry. We're trying to put this up with the IKDR, the International Kawasaki Disease Registry, siege in Toronto. And many Kawarabi people are part of the IKDR, but also will be invited to be part of it for that particular research study.
We can hear you, Dr. Ali.
Okay. Thank you. It is just again that I wanted to thank Dr. Ashraf and Dr. Naguib for their comments about the atypical and the incomplete, because we have to be thinking on both of them. And I am thanking you for thinking of looking at the eyes of the patient for those spots. What make you look at the eye, and this attracted your attention for that, Dr. Antoine?
I'll tell you, Dr. Alia, when the patient arrived 1 year ago, he was arriving basically with 7 days of fever. There was no obvious manifestations of Kawasaki, and the first echo was normal. So at this point, they were investigating the autoinflammatory disorders, other causes that can be manifested as a retinal manifestation, and this is why the patient had a fundus examination, and this is where they found a Roth spot. And I repeat what Ganna has beautifully said and showed that can we see a lot of cases? To my knowledge, I didn't see any case of Kawasaki reported to have a Roth spot, and it is partly explainable because we do not see the fundus in patients with Kawasaki routinely.
Yes. We are not looking for it. Yes.
Maybe this case might be site opening in understanding that some retinal manifestations might happen in Kawasaki, especially that if we know that coronary vessels have the same ultrastructure as retinal vessels. So it was somehow interesting raising this question to the audience.
So yeah, Dr. Al-Ghanim, go ahead.
Yes, doctor. My question is that what is the role of general pediatrician for early detection? If there is a screening tool, quick screening tool for a busy pediatric department to like highlight or make access for early detection of Kawasaki. Thank you.
So if the question is how to detect Kawasaki disease or the coronary problems?
Just make a high index of suspicion, and if there is a screening tool beside the first criteria for Kawasaki. So
Yes,
that,
exactly. So please hold on with us. So far, there are at least the American Heart Association, but also European recommendations to follow. But the coronary, which is a little bit more specific and more up to date, should come out early next year, early 2025. We will be including this discussion tomorrow in one session. Obviously, we cannot go over the whole recommendations, but we will get over this tomorrow.
Thank you, Doctor.
Pankaj? Yeah, go ahead.
Yeah, I'm Dr. Pankaj from Alliance City, UAE, Abu Dhabi. I'm general pediatrician. So the question which was asked, we as a pediatrician team in our hospital, any child coming with a fever of saying suppose 6 days, 7 days, the first point we do, we take proper fever history with a documented temperature checking and medicine giving the date and time exactly. Because most of the time what happens, over diagnosis and over treatment, over investigations are done. The many time history is not properly given. So if you think any fever coming 6, 7 days, and we keep on thinking Kawasaki every time, it will take over diagnosis and over investigation the process. So my comment was, as a pediatrician, general pediatrician, he has to sensitize how to take the fever history, which is a very, very important in all cases in the pediatrics. So we are seeing many cases. Dr. Suleiman is helping us a lot in our Alliance City because he is the only center which is helpful for us. Many times we get a problem of these cases. So we are able to diagnose and treat also in Alliance City. So this was my comment and question. So this was the topic of the talk for the fever content. Thank you.
Yeah, thank you very much. I guess you're you're attending from India, or am I wrong?
No, I am from Alliance City, UAE.
Well, I asked because of your name, obviously, but also because India is very strong in diagnosing Kawasaki disease. At least several centers have worked very hard for that. And we're trying to make education everywhere for the primary care physician, including in North America. It's still a need, but probably much less than anywhere else. So we're going step by step, by country and by regions, to make this ease of diagnosis possible.
Yes. Thank you.
Great. Thank you, everyone. I think we will wrap up this session. Typically, we have a few minutes of refreshment, but since everyone is at their home and their own comfort, I think we can move on to the next session.